Okay, hello. Thank you very much for joining me. Thank you very much for the organisers and for the chair for allowing me the privilege of speaking to you today. I'm going to talk to you about NAFLD, the patient perspective. Before I do, I'm going to ask you very, very quickly, would you mind just at your desk, if you're watching this presentation, can you just quickly jot down your name for me, please? Just very, very quickly. So on the subject of names, my name is Robert Mitchell-Thain. I'm Director of Patient Insights at the Global Liver Institute. I'm also the Director of Pediatric and Rare Liver Diseases at the Global Liver Institute. I'm also the Vice Chair of Liver Patients International, and I am a fatty liver disease patient. Now that you've written your name down, I'm going to ask you to do it again, but would you mind just doing it with your other hand? So put your pen in the other hand and just quickly jot down your name for me, please. If you could, I'd be grateful. Thank you. So when we talk about the patient perspective, the patient journey, there isn't one patient, there isn't one patient perspective, there isn't one patient journey. However, there are commonly discussed hurdles. We know the levels of awareness are not ideal. We know that screening is not ideal. We know there's no consensus on screening, which is not ideal. We know there's no clear clinical pathway. There are no current treatments available, which is not ideal. And then we have what we term the psychosocial issues. And this is the part that I really, really want to focus on. Now, just while I was talking about that, hopefully you will have jotted down your name again, but using your other hand. And I imagine if I were to ask you, how did that feel? Probably less comfortable, maybe challenging, maybe difficult, maybe awkward, maybe fun. I don't know. But what I asked you to do was to experience change. Okay, something as simple as writing your name. By changing one aspect of that, we have made it immeasurably more difficult than how we do on a daily basis. So I want to raise that with you, and I just want that to be in the background as we talk. So I'm going to go to the character now, Andy Capp. Now, Andy Capp is a comic character, and he goes to the doctor. He says, "Doctor, what is the best thing I can do to improve my health?" And the doctor says, wise words, "The best thing you can do is give up smoking, drinking, and fried food," all of which is common sense, all of which is sound medical advice. Yet Andy Capp's response is, well, actually, what's the second best thing I can do? And the reason I raise this is not to be disparaging or to speak in any kind of detrimental way about patients, but to highlight the patient journey. Because when we hear words like, oh, you could do with losing a few pounds, or you just need to get some exercise, all of those kind of things elicit what we call an emotional hijack. So when you look at this picture of the brain, okay, you've got what we'd call the cognitive part of the brain up the top, and then just underneath in the purple and in that kind of brown walnut area is what we have is our emotional brain. So when the doctor says to us, you need to lose a few pounds, or you need to exercise more, or any of those things, we don't think up here in our logical part of the brain, we don't think, oh, that's sound medical advice, I think I'll go and do that. No, we hear that, we perceive that as a threat. And so we hear that right back here in our emotional part of the brain. And that leads us to have an emotional hijack, which means you get an emotional response, which means we're not thinking creatively to produce a win-win or to create solutions or any of those kind of things. We just have this emotional, intense fight, flight, freeze response. So that brings us to our everyday reality of living with fatty liver disease, NASH, call it what you will. So the first thing is the visceral gut reaction. And so there's guilt. I've done this to myself. I should have known better. I should have done better. I should have made better choices. And we carry this each and every day. We carry this as individuals. We carry this as family members, as friends, as caregivers, as work colleagues. We carry that guilt. Now, I've deliberately put these in random order because what we go through isn't logical. It's not smooth. It's a whole series of events that all happen in a random manner. So the next one I want to talk about is managing change. Now, just a few moments earlier, I asked you to write your name in a way that was completely different to what you were used to. What's the norm? And you probably would have found that slightly uncomfortable. Now, I know there's lots of clinicians in the audience, and we won't even ask them to look at the two forms of the handwriting to see which is better, because frankly, They might be the same. But what I'm saying is that actually doing it, actually doing something different was more challenging, more difficult. Yet we're asking patients to go and manage change. Now, when you talk to the fellowships, Alcoholics Anonymous, Gamblers Anonymous, Narcotics Anonymous, they will tell you that round about, so AA, for example, will tell you that round about 2 to 3% of alcoholics make it into a meeting. Of that 2 to 3%, round about 2 to 3% come back again on a regular basis. And then once they're actually attending the meetings, it's those who are following a program, not necessarily the program, but a program, who are the ones that have the most success. Now, when you are following a program, your chances of success are enormous. But when you're not, you're a kite in the wind. And so this is one of the things I want to highlight about the patient experience, is that they are a kite in the wind. And yet we're somehow to manage change. And when you look at, abstinence programs or weight loss programs, there's a huge amount of support that is available there. But we're asking patients, telling patients they need to make these lifestyle changes, but there's no support mechanism to allow them to do that. Now, we can talk about nutrition security, not just food security, proper nutrition security. So we need to look at, inequality. We need to look at equity of access. We need to look at the societal norms. We need to look at paying an honest day's pay for an honest day's work. We need to look at all of these things, because these all have an impact on patients and on their NAFLD, on their chances of getting NAFLD, and on their chances of actually dealing with it and helping themselves. Okay, and the next thing I want to talk about is our family. Okay, do we live with enablers? Do we have people who kind-heartedly think, you know what, you've done really well this week, so I've got you a wee dessert for after your dinner tonight? Which is a lovely thing to do, but is it helpful in terms of people making change? If I change my diet, if I'm going to eat more healthy, if I'm going to exercise more, do I do it with my family? Do I take my family with me on that journey? Do my family volunteer to come with me on that journey? Or are we lost? Are we talking about sugar addiction? There's data out there that says that pound for pound, sugar is more addictive than cocaine. Yet we're not dealing with this. We're not talking about this. And we're not addressing this as one of the aspects of living with non-alcoholic fatty liver disease. Sugar has an impact, as does advertising. When you look at, adverts, and you go to the cinema, and there's the adverts for the popcorn and for the fizzy drinks and for everything else. You're watching a film at home on the TV, and there's the advert that is designed by psychologists to trigger your most primal responses. And you, as an individual patient, what chance have you got of actually being able to fight that day after day after day after day? And then there's things like shift work. There's things like dietary advice. There's things like shopping. Go to a petrol station. Stand in the queue for the petrol station, and what do you see eye line? Chocolate bars. Over and over again. Or the donuts, which happen to be cheaper than apples are. And on it goes and on it goes. One of the key things, now it's linked to nutritional security, but actually it's one of the things that we face as a patient population. Privilege. Now, I'm in a privileged situation. A male, middle-aged and white. So let's leave that to the side. I'm reasonably intelligent, some would say, not everybody. I'm reasonably good at communication, some would say, not everybody. And I have all these things that are able to help me in my journey and my struggle. And yet even I find it difficult to lose weight and to make an impact on my life, my quality of life, and on my NAFLD. So what chance are people who are not in that same position? Again, what chance have they got? And then I'll just throw it in there, setting a good example. Those of you that are in a clinical setting, when you look at your words, when you look at your language to patients, but also when you look at your vending machine, what is in the vending machine? I bet it's not healthy. So I want to talk about words matter, because I want to talk about patient advocacy groups. I want to talk about patient support groups. So when Andy Capp comes back and says, what's the second best thing you could do? The second best thing you can do is join a patient support organization. We see each other, we can mentor each other, we can support each other, we understand. And I always say to patients, if you think you're too small to make a difference, then try sleeping with a mosquito in the room. Again, you have my thanks, you have my appreciation. I'm Robert Mitchell-Thain, rmitchellthain@globalliver.org. Thank you.